topic will be focused on your therapeutic diets. Now, when I talk about therapeutic diet, take note that your concern here is not diet or the social notion about diet wherein we reduce the food intake of the patient. Here, our basis is the word therapeutic. In other words, we try to address the condition of the patient, the medical condition of the patient, and that should be addressed using their diet. Okay, so this will be an application of what you have learned from your lecture about the different gastrointestinal diseases. So this is just a reinforcement as to how can we apply the diet in the related learning experiences and then later on in your duties as nurses. Now, try to look at this definition first or learning outcomes. Now, in your learning outcomes, guys, what we intend is that after this session, you will be able to identify the different types of therapeutic diet and its indication. Okay, and understand the nursing consideration with each type of the therapeutic diet. Now, class, for each of the diet, there are specific interventions there that you need to watch out for. Okay, you need to watch out for specific interventions. Now, let's have the first diet on the list or the definition first. Class, when I talk about diet therapy, you have two bases there. The preferences of the patient and the patient's condition. When I talk about preferences, yes guys, there are diet wherein we consider the like and the dislike of the patient. But not all the time we would be sticking on what they like. Okay? Because oftentimes, for example, if I am dealing with a patient with dengue hemorrhagic fever, okay, class, take note of this. One special diet for a patient with bleeding disorder. If your patient would have bleeding disorders, the diet that you would have for them is NDCF. Now, can you tell me what is the meaning of NDCF? Okay, could you tell me what is the meaning of NDCF? Anybody? When I say NDCF, your NDCF stands for no dark colored foods. Okay? No dark colored food. So for example, if your patient would have your dengue hemorrhagic fever, the type of diet that you would have for that patient is NDCF. NDCF again stands for no dark colored food. Okay? Which means, class, for example, if a child would have a dengue, and then class, you suspect that the child would be possibly bleeding, could I allow the child to take spaghetti? That should be a no. Okay? That should be a no. Could I allow the child to drink grape juice? That should also be a no. Can I allow the child to drink Coke? That is still a no. Okay? So basically, class, dark-colored food are not allowed to be taken by the child. Now, the usual concern that you can encounter in the pediatric setting is that they will try to ask for spag because most of the children would love spaghetti. Okay, so for that reason, not all the time their preferences would be followed. Now, your next consideration for the preferences is their religion. Okay, religion. There are religions, class, who do not allow the intake of fats, especially the one that's coming from pork. Okay, they don't want that. That's against their religion. Okay, so for that reason, you need to consider that. Then you would have condition. For example, if your patient would have edema, secondary to chronic kidney disease, is it okay for me to increase the salt intake of the patient? Is it okay, class, to increase the salt intake of the patient? Or do I need to decrease the salt intake of your patient? Anybody on the chat? Will it be increase or decrease the salt intake of your patient? Okay? Class, you should decrease the salt intake of your patient. Okay? Decrease the salt intake of your patient. Remember, when I talk about edema, edema is equal to water retention. And then, class, if you have CKD, CKD is equal to no urine output. So what happens? Okay? And then, when I talk about salt, take note that salt loves water. Okay? Take note that your salt loves water. So if I will give a lot of salt to somebody who has CKD, I'm not actually just giving salt for the benefit of the patient, but I'm actually burying my patient 6 feet below the ground. Okay? You're not helping them. That's why the condition of the patient is always considered. Your goal is to attain and maintain a desirable body weight and level of energy. Okay? Again, your goal is desirable body weight and level of energy. Because take note, for example, even class, if your patient would be undergoing surgery, one of your consideration there is that your patient would be on NPO. When I say NPO, your patient would be nothing per orem. Okay, in other words, there will be no food intake for your patient. But your concern after the surgery is the recovery of the patient. During the recovery phase of the patient class, you would want your patient to have high caloric intake. Why high caloric intake? Because what would be the purpose class of the high calorie after surgery? Again, try to think. What would be the purpose? Why do I need to increase the caloric intake of my patient after surgery? Anybody? So class, the high caloric intake of your patient would be needed. About the first diet or first therapeutic diet. You have your regular diet. Oftentimes in the hospital setting, we will call this full diet. Okay, full diet. So when I say regular diet, it's usually a balanced diet intended for ambulatory patients. It may have a slightly reduced caloric content depending on the condition of the patient. And in that case, class, the examples are you have grains, you have your veggies, you have your fruits, your dairy products, and then your protein food. So if you get to be admitted in the hospital and that there are no conditions, you would have your regular diet. Now, what is your clear liquid diet? Class, in your clear liquid diet, this is indicated for short-term use only. Okay? Now, class, short-term use only, and it is for the purpose of preventing dehydration. It could be the initial feeding post-operatively. It could be used class for bowel preparation, for surgery, and also for your diagnostic test. Okay, also for your diagnostic test. Now, when I talk about clear liquid diet, basically class, it's clear liquid. Okay, clear. Meaning there are no particles floating there are no fibrous material floating there. Because or else that will not be considered a clear liquid diet. Now, look at this. Short-term use only. Why? Okay? Because class, if ever you will continue with a clear liquid diet for a long period of time, your patient would have deficiency in energy, deficiency in calories, and many other nutrients. Because your clear liquid diet will not be containing the calories that you need for your patient. Second, one advantage of your clear liquid diet is that it is easily digested and absorbed. For that reason, dear students, it is being used as an initial feeding post-operatively. Recall that if ever your patient would undergo surgery class, your patient would be first placed on NPO. If your patient is placed on NPO, do we right away proceed after surgery? After surgery, do we right away proceed to full diet or do I need my patient to pass first the clear liquid diet? Is it a full diet right away or do I need to pass by clear liquid diet? Okay, so it's a no. You need to pass by your clear liquid diet. Okay, because class, after your surgery, there needs to be a transition. There needs to be a transition. And class, that transition could be from your clear liquid, and then you'll have your soft diet, and then you would have your full diet. Or else, okay, or else you will place your stomach in shock, quote unquote. Okay, your stomach, which has had no contents for the past 8 to 12 hours, would have immediately a content. And that would put your stomach into stress if ever you would go to full diet right away. Next, there is minimal residue in the gastrointestinal tract because remember, okay, you're not putting any fiber there. However, your patients would find it unappetizing. And, class, you need to check the following. The fluid status of your patient. So you need to check the MIO of your patient. You need to check the weight of your patient because you are exploring if there is a possibility or if ever your fluid volume exists or fluid retention is happening, which means that your patient is having a lot of fluid intake already, or if your patient's fluid intake is inadequate, which leads to dehydration. Now, when we are talking about fluids, please be reminded that 1 kilogram of fluid, okay, is equivalent, or I'm so sorry, 1 liter of fluid is equivalent to 1 kilogram of weight. Which means, for example, if I have this patient, Okay? If I have this patient class, which would gain weight within, let's say, a week, my patient gained 2 kilograms. And I know that my patient has a kidney problem. I would suspect already that my patient is having fluid retention. In other words, the fluid that my patient is taking in is not actually absorbed by the body. It's not actually used by the body. Instead, it is being retained somewhere in the body. Okay? And that may be already your third fluid shifting. Okay? Or what we refer to actually as your third spacing. Okay? Again, the term for that is third spacing. Okay? Third spacing, or what we refer to as fluid shifting. Class, for you to remember third spacing, this is a concept under your fluids and electrolytes. For you to remember your third spacing, I would usually say they are the fluids in the wrong spaces. They are the fluids in the wrong spaces. In other words, supposedly, we don't have fluids in our lung cavity. But if you have third spacing, you would have pleural effusion, excess of fluids in the lung cavity. Now, since we have been talking about patients undergoing surgery and then would go into clear liquid diet, what would be my basis before I will start my post-op patient? Again, what would be my basis before I would start my post-op patient on diet? Before I would give clear liquids to my patient, what would be my important assessment? Anybody? What would be an important assessment that I need to do before I would give clear liquid diet to my patient post-operatively? Class, you need to check for the functioning of your gastrointestinal system. And that is, class, there are two ways for you to check that. The presence of your gag reflex. Okay, your gag reflex. And then another one is the passage of flatus. That's why when your patient would undergo surgery, we are very worried if they have already had their flatus or utot. Okay, because class, that would indicate that the gastrointestinal tract is going back into function. The gastrointestinal tract is already working after anesthesia. Okay, after anesthesia. So that for that reason, you need to check the gag reflex and the flatus. Question, how about if the patient is very hungry, the patient is wanting to take food, however, the patient has not had flatus, or your patient did not have gag reflex yet? What would you do? Will you give your patient water still, or will you still wait for the gag reflex and flatus? So class, you have to wait for the gag reflex and flatus. If after some time after surgery, the patient still does not have flatus, you advise your patient to turn to sides. And if tolerated and if warranted by the condition of your patient, we would even advise the patient to ambulate. In other words, we would tell the patient, walk around the room so that your GI tract would be functioning again. Okay, that's how it works for your clear liquid diet. So try to remember those important concepts. Now, let's go to your low cholesterol diet. Now, when we talk about low cholesterol, basically no fat. Okay, no delicious food, no lechon on the table, no fried food on the table, no canned goods on the table. Because those things that I have mentioned are the very high sources of your cholesterol. Okay, the very high sources of your cholesterol. Now look at this. Your low cholesterol diet, dear students, is indicated for a patient with heart disease, a patient with atherosclerosis. Recall that when I say atherosclerosis, this is usually related to the build-up of fatty substances on the arterial walls. Okay, build up of fatty substances on the arterial walls. Then you have your diabetes mellitus. You have your hyperlipidemia. Dear students, hyper is increase, and then lipids is still your fats. Hypertension, myocardial infarction, nephrotic syndrome, damage to your kidney, and renal disease, especially your CKD. Now, remember that when I talk about cholesterol, there are two primary types of your lipoproteins. You have your LDL and your HDL. your low density lipoproteins and then your high density lipoproteins. Okay? Between the two, LDL and HDL, what is considered to be a good cholesterol? What is considered to be a good cholesterol? Is it your LDL or your HDL? Okay, class, that will be your HDL. Because remember, class, this is how we remember this. HDL high should be high. Okay? We want HDL to be high. That's why high should be high. Give me an example of a high density lipoprotein. Give me an example of your HDL. Dear students, that would be coming from your fish oil. Okay, one typical example that we give to our patients is your fish oil. Okay, try to take note of that. Now, when I talk about your low cholesterol diet, that includes your DASH diet. Class, your DASH diet means DASH, dietary approaches to stop hypertension. Again, that would mean dietary approaches to stop hypertension. That's your DASH diet. Now, restrict the total amount of fat that your patient is taking. If your patient class has a heart disease and then your patient consumed a lot of lechon, your patient consumed a lot of fats, okay, in some minutes, guys, after consuming the fats, they would sit down on the side and then they would appear to have like this. Okay? And then they would be burping from time to time. Class, that's the signal that they're already having chest pain. Okay, they're already having chest pain because of the high cholesterol. That's why these are the indications for this condition. Now, let's talk about the succeeding disorder or the succeeding diet. You have your low fiber diet. Oftentimes we hear you eat high fiber. High fiber is good for the heart, good for the intestines, good for the stomach. It's always high fiber diet. But dear student learners, there are instances wherein we need to have low fiber diet. What are those times? Okay? When do you think do I need to have low fiber? If my patient is having constipation or if my patient is having diarrhea. Again, when do I need to have low fiber diet? Is it when my patient is having constipation or if my patient is having diarrhea? Okay, let's think twice. Okay, when should we have low fiber diet? Constipation or diarrhea? Dear students, your low fiber diet is used for a patient with diarrhea. Okay? Again, your low fiber diet is used for a patient with diarrhea. Okay? Why, guys? Why? Okay? Class, take note of this. If your patient, okay, if your patient class would have, okay, class, if your patient would have constipation, you would want fiber in the diet. Okay, again, if your patient has constipation, you would want fiber in the diet because remember, class, it is the fiber that would form the bulk of the stools so that it would be easy for the stool to go out. Okay, that's the job of your fiber. That's the job of your fiber. So again, if my patient is constipated, I would want high fiber diet because high fiber would make the stool soft, easy to go out. Okay, it would make the stool soft, easy to go out. Okay, now, in a while. Now, for your low fiber diet class, for your low fiber diet, it's indicated for a patient who's having diarrhea. Look at the conditions. IBDs. IBD is inflammatory bowel diseases. If there is inflammation in the intestines, what do you think would happen? Is the intestine not moving or is the intestine irritated and moving a lot? What do you think happens if there is an inflammation in the intestine? Will the intestine be in pause or will the intestine be moving a lot? Okay, class, your intestine will be irritated and then it will be moving a lot. With that, class, your patient with IBD would have diarrhea and a lot of diarrhea. And because of that, class, we are not giving high fiber because diarrhea plus fiber, more diarrhea, dehydration. Again, diarrhea plus a lot of fiber would lead to a lot of diarrhea, leading to dehydration. Next, partial obstruction of the intestinal tract. Guys, if there is partial obstruction of the intestinal tract, here's what's happening. Okay, class, for example, this is your intestine. Okay, normally, guys, your intestine would be continuous, your intestine would be open, okay, such that the stool will be able to pass through. Now, what happens in your partial obstruction? In your partial obstruction, there is obstruction. There is obstruction of your, in a while class, there is obstruction of your intestines in such a way, class, that the obstruction will prevent the entry. The obstruction will prevent the entry of your stool products. Okay? In partial obstruction, what happens is that, okay, class, if this will be the intestines of my patient, there's a block, okay, as the term obstruction implies. So class, if I will be giving a lot of fiber to my patient, if I will be giving a lot of fiber to my patient, will the fiber be able to go out, or will the fiber stay and get stuck there? Will the fiber be able to go out, or will it stay and get stuck there? So class, what would happen is that it will stay. It will get stuck there. So what will happen? There will be dilation, there will be enlargement of your intestines until it will possibly rupture. And we don't want that to happen. That's why in partial obstruction, class, unless the patient have already been operated, unless if the patient have already been operated, class, you need to give low fiber diet. Okay, you need to give low fiber diet to your patient. Okay, I hope that this reminds you that you need to understand the pathophysiology of the disease for you to understand why they have this type of diet. Now, gastroenteritis. Okay, class, you've seen there the word itis. When you have the word itis, what should be the next word that should come into our minds? We should remember, if there is itis, there will be inflammation. There is inflammation. And if there is inflammation in the intestines, the next word is irritation. And if there is irritation, there will be diarrhea. That's why, class, it's not of help to your patient with diarrhea to give fiber. You will be exaggerating their diarrhea episodes. Now, for your low fiber diet, one also of the consideration is to limit the dairy products to 2 servings. Why, class, there is also a possibility that this dairy product could aggravate the diarrhea of your patient. So you need to check if your patient is lactose intolerant or not. Okay? Now, class, so for your low fiber diet, take note, your vegetables would be a good source for that. Okay? Your vegetable is a good source of fiber. So don't give it to your patient who is on low fiber diet. Your nuts and seeds also, class, your plant fiber and your whole grains, okay, must be limited to a patient who are having low fiber diet. Next, you have your diabetic diet. Class, when I talk about your diabetic diet, as the term implies, it is for patients with diabetes. We have 2 kinds of diabetes, DM1 and DM2. Between the 2, who is considered to be insulin dependent? Is it the DM1 or the DM2? Between the 2, who is considered to be insulin dependent? Is it DM1 or DM2? Insulin dependent diabetes mellitus, class, would refer to your DM1. Okay? Class, that's why another name for your DM1 is IDDM, insulin dependent diabetes mellitus. Now, DM2. When I talk about your DM2 is NIDDM. Okay? Non-insulin dependent diabetes mellitus. Non-insulin dependent diabetes mellitus. Okay, that's your NIDDM. Okay, now, with that 2 words, class, or that 2 pairing that you need to remember, DM1 insulin dependent, DM2 non-insulin dependent. If I would just based on that pairing, which do you think, or what type of diabetes you think had a complete absence of insulin? What type of diabetes you think would have complete absence of insulin? Aha. Look at that. Insulin-dependent diabetes mellitus. Insulin-dependent diabetes mellitus. In other words, he needs insulin. He depends on insulin. For that reason, class, your DM1 is the type of diabetes wherein there is already destruction of pancreatic cells. Pancreatic cells are destroyed, zero insulin at all. Okay? That's why, class, your DM1 is referred to as insulin-dependent diabetes mellitus. Your DM2 class patients are able to produce some insulin. However, this insulin is not adequate. This insulin is not adequate for the patient to decrease the blood sugar levels and for the patient to utilize the blood sugar. Okay? Plus, why I'm saying utilize the blood sugar? Because what actually happens in diabetes is that, recall that the purpose of your insulin supposedly is to make use of the sugar. Your insulin is intended to make use of the sugar. But what happens in diabetes? You have a lack of insulin or you have absence of insulin. The sugar class could not be used. That's why your patients with insulin are taking a lot of food because they think they are hungry. They are taking a lot of food because they think they still need more sugar. The body thinks that it needs more sugar. Okay? So for that reason, class, that's the purpose of your insulin. It could not, so in diabetes, your diabetes patients could not make use of the sugar. They could not make use of the sugar available to them. Now, what happens in diabetes? Class, when I talk about diabetes, oftentimes the misnomer or the misconception that our patient has is that they will diet. Okay? They will say, oops, I have diabetes, I will diet. And when a Filipino says he will diet, the usual definition for that is the reduction of food intake. Okay? And sometimes abrupt reduction of food intake. Okay? You know that feels that sometimes you feel I'm fat, I would not eat. Okay? So that's not beneficial. What happens? Class, in your diabetes mellitus, you are not supposed to abruptly decrease the food intake of the patient. It's not also practical, feasible, and ideal for you to limit the food intake of your patient. If I will be limiting the food intake of my patient, what would happen? My patient would have hypoglycemia. My patient would have hypoglycemia. Okay? So class, this is the usual situation. Somebody knows she has diabetes, that person will tell himself to diet and then would abruptly reduce food intake, and then later on, class, they would have hypoglycemia, and then class, severe hypoglycemia could actually lead to rest in peace. Okay, class, your patient will be 6 feet below the ground for severe hypoglycemia. So don't do that. So sir, what should be the diet for a patient with diabetes? Class, we divide. As indicated there, you divide into 3 meals and 2 snacks. 3 meals and 2 snacks. If you are in the hospital setting, the physician, for example, would order, have a diet for patient X, 1,800 calories divided into 3 snacks. Where's the divided to 3 snacks? Divided into, okay, 3 meals, and 2 snacks. Sir, why do they need to have 5 intake in a day? To prevent hypoglycemia. Okay, to prevent hypoglycemia. So class, that means do not abruptly decrease the food intake of a patient with diabetes mellitus, and then other than that, they need 3 meals and 2 snacks. Sir, why are they at risk for hypoglycemia? Because, dear students, they are on your OHA. They will be in your OHA. Your OHA is your oral hypoglycemic agents. Okay, that will be your oral hypoglycemic agents. And one major side effects of your OHA, okay, is your hypoglycemia. Okay, as obvious as it could get, it says oral hypoglycemic agents. Okay, kindly take note of that. Now, for the next diet that we have on the list, that would be your Okay? Low calorie diet. Low calorie diet. Take note that class, low calorie diet is different from low sugar diet. Look at this. Low calorie diet is indicated for a patient with hypoglycemia. Oops, hypoglycemia but low calorie diet. Okay? And of course, obesity. You understand, obesity need to reduce calories because more calories, more fats. But how come, class, a hypoglycemic patient would need to have low calorie diet? It's because, class, the high calorie diet leads to slow absorption of glucose. Again, the high calorie diet would lead to low or slow absorption of glucose. So what happens? If your patient will take a lot of calories and then your patient's glucose will be slowly absorbed, she will think or he will think that, oops, I'm still hungry. Let's eat more, let's eat more, let's eat more. Okay, so it's not helping your patient. That's why there needs to be low calorie diet. Now, high fat content may be slow for the absorption of the glucose and resolution of hypoglycemia. That's the reason. And then obviously you should avoid high calorie food products. Next, high caloric and high protein diet. Okay? When do we use your high caloric and high protein diet? Plus, your high caloric diet and your high protein diet are used for the following conditions. Severe stress. Okay? Severe stress is one. Okay? Another one is burns, wound healing. Class, for those three conditions, the reason there is that you would want to increase the healing process of your patient. Next, cancer. Okay, class, in cancer, your patient needs a lot of calories because he is not only feeding his cells, the cancer cells are competing with the resources available in the body. HIV/AIDS to combat the virus. COPD to increase their immune system. Respiratory failure to prevent respiratory edema or pleural effusion. And then your hypoalbuminemia. Class, when I talk about hypoalbuminemia, okay, when I talk about hypoalbumin, take note that your albumin is what type of macronutrient? Is it a carbohydrate or a protein? Okay, class, when I talk about albumin, okay, class, your albumin is a protein. Okay, for that reason, class, if your patient has hypoalbuminemia, I would need to give high protein diet. Okay, take note here of the highlight that I would need to emphasize. Class, in this case, this is a liver failure case, class. But your patient is having hypoalbuminemia. Take note that there will be different cases when you are dealing with a patient with liver failure. Okay? There will be different cases if you're dealing with a patient with liver failure. There will be times that you will give them high protein. There will be times that you will limit their protein intake. Okay? So class, you will know more of that when you will be discussing your liver failure. But in this case, class, you would want to have high protein diet because your patient is having hypoalbuminemia. Now, a good source of albumin for that matter. Give me a good source of albumin, a very common food that we take. Okay? Egg. Very good. Egg. Okay? For that reason, dear students, sometimes you would encounter orders wherein they would say, add 2 egg whites on the diet or NGT feeding plus 2 egg whites. Okay? They would do that to increase the protein intake of your patient. To recap, what's the purpose of your albumin? Dear students, remember that your albumin is the one that maintains your oncotic pressure and your osmotic pressure. I'll use the term osmotic pressure. It maintains your osmotic pressure in such a way, class, that if you would have decreased albumin, your fluids would be shifting. Okay, your fluids would be shifting from intravascular space to extracellular spaces or extravascular space, I mean. Okay, class, this results to your edema. For that reason, if your patient has edema, the next test that your patient would order or that your doctor would order, class, for your edema is to have your protein test. Okay? Class, the test for that is TPAG. If the doctor will say, TPAG, hey nurse, let's have TPAG. TPAG class is total protein, albumin, and globulin. Total protein, total albumin, and total globulin. Okay, those are the tests that you need to have for your patient. Okay, so class, once albumin is decreased, expect the doctor will say add egg white to the diet. Then, class, for this case, high caloric diet, we encourage our patient to have snacks. We encourage our patient also to perform caloric counts. What do we mean by caloric count? Class, we collaborate with the nutritionist dietitian and then we tell them, okay, we ask the nutritionist dietitian, could you provide the diet exchange list? Class, the term for that is diet exchange list. Okay, class, your diet exchange list will be able to say, one slice of beef is equivalent to this number of calories. Or they will be able to say that 2 loaves of bread is equal to 1 cup of rice is equal to this number of calories. In that way, the patient will be conscious. Okay, the patient will be conscious on the number of calories that he or she is taking. Other than that, in the current trends class, you already have applications. Okay, applications available in Google, applications available in iStore, okay, that could able to, or Apple Store class, that would be able to help you, that will be able to help you account the caloric intake that you would have. Next, low protein diet. Okay? Class, your low protein diet is intended for the patients with hepatic encephalopathy. Dear students, hepatic encephalopathy is still a complication of your liver failure. Okay? It's still a complication of your end-stage liver disease. Okay? Sir, earlier on the previous slide, you mentioned high-protein diet. Class, there will be different instances for hepatic encephalopathy and liver failure. Okay? In liver failure, there will be times that they need low-protein diet. There will be times that they need high-protein diet, depending on the condition. Okay? So, you will be discussing that in the future. So, provide enough protein. And then you have the special low-protein pastas, low-protein products. So, the pasta, the cookies, the wafers class, the gelatin. Okay, so they would have usually low-protein content. And then you would have vegetable and fruits that can provide additional energy for your patient. Class, why do I need to limit the protein intake of this patient? Okay, class, protein, earlier we said that protein, sir, is good because it would have calories. Calories would lead to healing. Okay, yeah, that's true. But in the case class that protein, the waste product class of your protein is ammonia. The waste product of your protein is ammonia. And ammonia is the cause of your hepatic encephalopathy. Oh, if that's the case, will you still increase the protein in the diet? Of course not, because you know that the protein there could lead to increased ammonia. The body is unable to excrete that ammonia because of liver damage. It would lead to more problems on your brain. Encephalopathy. Encephalopathy is brain. Okay? Complication class of liver problem, complication manifesting on the brain because of the liver problem. Now, low-fat diet. Class, low-fat diet is used for patients with abdominal pain. It's also used for patients with steatorrhea. What do I mean by steatorrhea, dear students? Steatorrhea. What do I mean by steatorrhea? Class, your steatorrhea is the presence of blank in your stools. That's the presence of fat in your stools. Very good. Okay, class, flatulence, and then diarrhea. Okay, class, all of the above conditions, if you can take note, these are abdominal discomfort. So class, if your patient is having abdominal discomfort, it's not wise for us to give high-fat diet because that would aggravate the abdominal discomfort. Pancreatitis. Class, why pancreatitis? Take note that your pancreas produces two important enzymes. Okay, class, the two important enzymes produced by your pancreas are, let me recall, so you have your amylase and lipase. Okay, amylase and lipase. So, anong connection on the low-fat diet? Class, If your patient would have a lot of food intake, fat food intake, pancreas will work hard. If your pancreas is inflamed, such as pancreatitis, if your pancreas is inflamed, such as in pancreatitis class, and then your pancreas will work hard to release amylase lipase, just to digest your fat intake, you are adding insult to the injury of your pancreas. You are adding insult to the injury of your pancreas. Okay? The same way in gallbladder disease. If your patient class has gallbladder disease, take note that your gallbladder is the one that stores bile. Your gallbladder is the one that stores bile. What's the function of bile? Class, your bile is in charge for the metabolism of fats. So, if you have a gallbladder problem, okay, example, if the patient has a gallbladder problem, and then the patient class would have high fat intake, what would happen? The bile would contract, or sorry, the gallbladder would contract. The gallbladder class would contract, okay, to release bile, because the purpose of that is to release bile, to digest what you have taken. But because of that release of bile class, that will result to increased pain. Okay, increased pain. Okay? Now, GERD. What is GERD? Anybody who has an idea on what is GERD? Very good. Gastroesophageal reflux disease. Okay, so class, your gastroesophageal reflux disease basically is manifesting as heartburn. Okay, it's manifesting as heartburn. Okay, you know that feels wherein your patient will say that when they belch, something's going out. Okay, they're belching, they're burping, there's some acid going out. Heartburn. That's your GERD. Class, your fat is also equal to your acid. The more fat you take, the more acid the stomach needs to produce. And class, it will aggravate, it will worsen your GERD symptoms. Okay? Class, for the low-fat diet, there will be instances that the doctor will order for fecal fat test. Class, the fecal fat test is intended to test for fat malabsorption. Okay, it's intended to test for fat malabsorption. Next, low sodium diet. Okay, low sodium diet. Class, when I say low sodium diet, low salt diet, you decrease that salt in your diet. Why do I need to decrease the salt in my diet? Class, the conditions: hypertension, heart failure, renal diseases, cardiac diseases, liver diseases. Class, all of these symptoms in their severe forms would lead to edema. All of these symptoms would lead to water retention. And again, as I have mentioned earlier, salt loves water, and water loves salt. Class, salt, we equate that to sodium. The more salt you take, okay, class, the more water will stay. So, class, what would happen? If your patient has already hypertension, and then, class, there will be water retention, I can say that there will be more hypertension. Okay? More hypertension. In other words, class, you are aggravating the hypertension of your patient. The same in renal disease. Class, what happens in renal disease? Renal disease, is the kidney able to excrete the water properly? Again, if my patient's kidney is damaged, is the kidney able to excrete the water properly? Class, the answer for that is no. Okay? No. Since, class, water could not be excreted by the kidney, and then, class, your kidney is also the one that excretes your sodium. Okay, class, if water and sodium could not be excreted by the damaged kidney, and then you give more salt to your patient, you are actually adding insult to injury again. That would be more edema. That would be more retention. That would be more heart failure on the part of your patient. Okay, so again, just remember, salt loves, water loves salt. Wherever salt goes, water goes. Okay, those are the concepts for your sodium and fluid. So, class, there are different levels, no? So, you have your 4 grams of sodium daily, that's the usual that we take. 2 to 3 grams, moderate restriction. 1 gram, class, for strict restriction. Then 500 milligrams for severe restriction. The common misnomer, misconception among our patients. When we say low salt diet, some of them will just not put salt to their food. Okay? You will say low salt diet. Some of them, class, will not have salt on their diet, will not add the condiments to their diet. But class, they failed to realize that we have food products that even if you will not add salt to the food product, that product would still contain sodium. Okay, that product would still contain sodium. So class, when I say low salt diet, low sodium diet, you also cut off your processed foods. Processed food, you also cut off your canned food products because these products are very high in salt. You also cut off your dried fish, your dried products because these products are also high in salt. So when I say class strict restriction on the diet, that's basically no canned food, no processed food, okay, for that matter. Then you also class read the nutritional packaging, okay, or the nutritional facts there on the product packaging. And then after that class, salt substitute could improve palatability. Oops, is there a salt substitute? Yes, dear students, there's a salt substitute, but your salt substitute is composed of, okay, class, potassium. Your salt substitute is composed of potassium. So what if it's composed of potassium? Too much intake naman of the salt substitute would lead to potassium problems. And potassium problems equate to heart problems. Okay, so that's also a. Then you have your bland diet. Class bland diet, you have your GI ulcers, mouth sore, nausea, and vomiting. So when I say bland diet, that's basically no spicy food, no irritating food products in the diet. We also avoid your coarse, fried, and highly seasoned food, as well as carbonated food and caffeine drinks. So class, this is usually intended for patients who would have GERD. This is intended for patients with GI ulcers. Class GI ulcers, that's an acid problem. Patients with mouth soreness, okay? We don't want that because if you'll be eating spicy food and irritating food, your mouth sore would be aggravated. And then, of course, nausea and vomiting. Okay, so class, these are the special diets that we can take note of. These are the references. If you have questions, you could raise it.